A quorum, so we'll go ahead and get started. If we could please call the roll.
Senator Berg,
Oh, yeah, I need.
Senator Carroll, Senator Meredith, Senator Richardson, Representative Heverin,
Here.
Representative Marzian, Representative Mosier, Representative Williams, Vicky Yates Glisson, Holly Harris, Joe Petrie, Steve Shannon, Senator Douglas,
Present.
Senator McDaniel, Representative Bowling,
Here.
Representative Petrie,
Here.
William Baker,
Here for William Baker.
Laura Sudkamp, John Hicks, Lisa Lee, Sheila Schuster, Stephen Stack, Tom Stevens, Co-Chair Fleming,
Present.
Co-Chair Rocky Adams.
Here. Okay, today is Wednesday, September 24th, 2025, and we have a quorum for the Medicaid Oversight and Advisory Board meeting. Our first order of business is the approval of the minutes from the September 9th, 2025 meeting. Do I have a motion?
So moved. Second.
I have a motion and a second. All those in favor signify by saying aye. Aye. Any opposed? Okay, the minutes are approved. Okay, the next item on our agenda is, for context, it's a continuation of a discussion that we had from our last MOAB committee meeting where we were discussing the Medicaid waivers. We had a lot of questions, and apparently that conversation, I think, needed to bleed over into this committee meeting. So at this time, I would like to call up Leslie Hoffman and Carmen Hancock, if you all could make your way to the table. And ladies, please introduce yourself for the record.
Leslie Hoffman, Deputy Commissioner for the Department of Medicaid Services.
Carmen Hancock, Division Director for Long-Term Services and Supports with Kentucky Medicaid.
Thank you. And you know what, I was discussing this with Co-Chair Fleming yesterday, and we probably should have been doing this from the get-go, but we decided that we would probably go ahead and swear in everybody as we continue on with these committee meetings. So if you would please raise your right hand, and do you swear or affirm to tell the truth, the whole truth, and nothing but the truth?
I do.
Yes, ma'am.
Thank you.
I do.
Now please proceed. Okay, I guess we're just doing questions. So committee members, do we have any questions? Co-Chair Fleming?
Thank you, Madam Co-Chair. Thank you all very much for coming last week or whenever we met last time. But we do want to have a couple of questions to follow up on, just for clarity and so forth. In the conversation last time we met, we talked about the waiver list management assessment report, and in that there's recommendations in there as far as align wait lists, administration regs and policies across waivers, standardize waiver app and waiting list placement process, and modernize a wait list management data collection systems. And that was about a year ago. And I want to see if you can provide and shed some light on your status and how that's progressing.
I want to make sure I have the right notes for the right conversation here. So in the 2024 waitlist management assessment, yes, we had those recommendations. We also provided on the last slide timelines, which several of those went into 2027. Align wait list management, administration regulations and policies across the waivers, standardizing waiver application, modernizing the wait list. This is all work that we have been doing. in a joint process with the Department for Aging and Independent Living and the Department for Behavioral Health, Developmental and Intellectual Disabilities. We've been doing that work as sister agencies. We've had 2 task forces on this work. We have been provided with feedback and recommendations, but as we've mentioned previously, having to expend the ARPA dollars put a little bit of a hold on our ability to actually take action. So we have reinvigorated this work. That task force is actively working to implement, the recommendations that we've come up with, and we're hoping to be able to put through regulations and that sort of thing sooner than later, so that we can sort of sum this work up and tie a bow on it.
And what's your time frame? How quickly are y'all gonna do this?
So our time frames go through, the last one is March of 2027. So we still have a couple of years to go.
Okay. I have another question, if you don't mind, Co-Chair. When we met last time, I asked about all the various waivers in terms of a cost per individual. Did y'all come up with that?
Yes, sir. Leslie's going to take that one.
And explain how you determine those numbers.
So these particular ones are, I had told you that I had some averages that I could share with you, and we base those on pulled claims. So paid
Is
claims.
your microphone on? I have
Sorry.
trouble hearing.
I'm usually having it over here. I'm so sorry.
Okay.
Can you hear me now? I'm so sorry. So we pulled averages based on paid claims to members, and pulled those claims and compared to those and developed them into a report for you. And we did 23, 24, and 25 for each waiver. So these are based on paid claims. Now, things that you can think about might be that providers have a year to bill sometimes. There's also, there might be lag time in a waiver getting up and started if it's brand new in a year, those kinds of things. So these are averages for per member, per month, and per year. So for ABI, this is ABI Acute, which is our rehabilitation waiver in nature. For state fiscal year 23, it was $124,639. For 24, fiscal year 24, it was $150,946. And for fiscal year 25, it was $147,432.
And that's per individual, correct?
Yeah, that's per member. Mm-hmm. And then, and again, these are averages. Okay.
Got it.
And
Go
so
ahead.
ABI long-term care for year 23 is 100 and 121, so 100,121. For fiscal year 24, it's 108,660, and for fiscal year 25, it's 109,44. For the HCBS waiver, year 23 is 48.
Sorry, it's like $10,944.
No, $109,044
Okay.
for fiscal year 25 on
Thank you.
ALT.
I got my
Sorry.
zero. Go ahead.
You're fine. Okay, and then HCBS waiver for fiscal year 23 is 48,537. Fiscal year 24 is 54,009. Fiscal year 25 is 60,843. Then model waiver 2 is for fiscal year 23 is 125,953. For fiscal year 24 is $104,056. Fiscal year 25 is 109,854. Michelle P. waiver for fiscal year 23 is $38,044. 24 is $42,877, and fiscal year 25 is $49,497. The SCL waiver, supports for community living, for fiscal year 23 is $91,160. Fiscal year 24 is $100,178, and fiscal year 25 is $105,376.
And how do you compare that with other? Is there anything other comparable that you can see if you're in the ballpark in terms of these? I assume not, but I just want to ask the
So,
question.
for waivers, when I'm giving you averages, that's not how a waiver is actually calculated. A waiver is calculated different, and it's not on averages; it's on aggregates. And I can explain that to you. I have the information if you'd like for me
Please.
to go through it. But I came up with the averages for you. So you can't take the averages and then multiply them by 10,000 members and then figure out what the waiver cost. That's not the way a waiver comparison is completed for budget neutrality. First of all, I feel like I do need to mention it is important that we approach terms like savings, cost savings, and return on investment with care and clarity. Fundamentally, this is a qualitative matter rather than a quantitative. For our waiver members who are thriving in our Kentucky communities and living independently rather than being in an institutional setting, this is an invaluable opportunity for them to experience an improved quality of life. The fact that we are able to support them in the community with the cost of the cost being less than or equal to facility-based care really represents a meaningful win-win for everyone. It's not just the financial return on investment, but it's a true advancement for Kentucky members to be able to be empowered to live and have independence and dignity and respect and well-being. So I always feel like I need to share those things because I'm truly a public servant and we love our programs and love our people. As far as the savings go that you had asked me before, it's not based on a member level. It's based on an aggregate, and I wanted to explain that to you if I may. The waivers are managed by what we call an aggregate to assure that cost neutrality is being contained. An aggregate in this case refers to a lot of information. It means multiple measures, multiple sources, variables, the individuals we compare, the level of care we compare, we have different comparisons for each waiver based on what type of facility that CMS will allow us to compare to. They also all have different waiver years. Statistical analysis is created and analyzed and sent in for CMS to review. Just to let you know, this means that services for many individuals may be a lot less than other individuals. Other individuals may have high needs where others may have lesser needs. Our budget neutrality, or what may be considered your return on investment, is based on a comparison, like I said, of many different things. We compare some waivers to ICF IIDs, which is intermediate care facilities. We also have some that we compare to nursing facilities. Our brain injury waivers are actually approved by CMS to have a comparison of a distinct part unit for people with acquired brain injuries inside of a nursing facility. So that's pretty complex, and there's very few comparisons to use in Kentucky, so we have to get those approved by CMS. We also have to take in consideration when we're comparing. So I'm going to give you an example. If I'm comparing members in the SCL waiver to members who are, their approved comparison rate is an ICF IID, for example, like Oakwood, they don't take the CMS does not take the full number of individuals that we have in the waiver for that comparison. They compare also days of stay. So they want to know what is the average day of stay in an ICF, what is the average days of stay in a waiver. They carve those members out and they compare those members with the same days of stay. I know this is complex, but so there's a lot of things that go into budget neutrality. I can tell you, if it helps, that we are in compliance with budget neutrality. That means that we are equal to or less than, and actually all 6 of our waivers are less than the cost of institutional care. This was completed through a review by CMS and approved, which we call an 18-month lag review. Again, I know that's the language sounds confusing, but because there's a lag in time for providers to bill, because there's a lag in maybe a waiver getting up and going, or that it needs time to ramp up, they allow us what they call an 18-month lag to go back and complete the analysis. So as of 22 and 23, fiscal year 22 and 23, the last lag report completed did find us in compliance for equal to or less than the cost of institutions in all 6 waivers. I do also want to mention that When you compare a waiver member, you also have to take in consideration their straight Medicaid cost. So even though you're in a waiver, you also have doctor's visits, medication, hospitalization, psychiatric hospitalization, or care that you might have to go outside of the waiver. And those things are not counted in the waiver. So we have to add those two things together.
Okay, my co-chair's kicking me in the shin because she wants to ask a question.
No, I was just gonna dovetail off of that. So what happens to the appropriated funds when a waiver slot is not used or partially used?
If it's utilized one 15-minute increment within the waiver year, we can, and it's vacated, we cannot reissue it until the next waiver year. So 4 of the waivers have May as a waiver year, one has October, and one has August. So if somebody vacates a used slot by one 15-minute increment, other than death's different, but we cannot reallocate that slot. It's part of their unduplication methodology. We cannot reallocate it till the next waiver year.
So what
Did
do
I
you do with
answer
the
your
money?
question?
Do you just hold it? Do you just turn it back?
No.
You just
So only the services that are billed would be coming out of the
okay.
money.
Only the service is
Yeah.
billed. Okay, and so like if you have an open slot, so like let's say I think we have open slots in Model 2 and ABI. Is that something where we should shift that funding to other waivers that have waiting lists?
So we have the number of slots that we have is based on an appropriation that we've asked for at some time. So I wouldn't want to potentially cause a futuristic waiting list if we allocated those differently. I think I've mentioned too that we do hold some slots for Money Falls the Person to help assist folks to move out of nursing facilities or ICFIDs. So we do have some of those that are reserved. It's just a handful. I think there's five in ABI.
Okay, sorry, I didn't mean to jump in.
Now, just a clarification, and I appreciate the explanation of the costs. I'm going to assume, and I'm not to be geeky here, but I'm going to assume these are not fully loaded cost allocation type of cost in providing the service. So what that means, basically, you told us that basically you look at the claims and you come up with that's what it is. And there might be some embedded components within that cost, but there's also your time. You have all these other types of ancillary components that come into that. So I suspect whatever that is, and that's one thing that drives me crazy in this government is that we don't look at a fully loaded cost allocation type of a process, but it is what it is. Imagine this is much higher than what it is. When I say higher, I use that word loosely, but I've got to believe these are somewhat higher. Do you think that the cost for each one of these waivers is reasonable? Is it? I'm going to say it's justifiable because we're here. I'm not all about numbers. I mean, I go through numbers. That gives me some fundamental understanding, and then I look at how to improve the value of providing that service, and I look at the cost to increase that. Mm-hmm. Is it digestible? Can we do that? Do we see a benefit in doing that? So that's where I'm coming from. So can you give us a little idea or thoughts from y'all's point of view in terms of the cost of each one of these particular waivers?
Based on the information that I gave you, that's for benefits only. I'm giving you all benefit information. Of course, we do, if you're asking about admin costs, we do have
that's
all
right, and that needs to be included in here too. I mean, that's what I'm saying. That's not included admin costs, right?
No, this is only benefit costs for per member that's
okay.
Right.
So the thought would be somehow take the admin costs, apply it to each of these waivers, and you can come up with the overall cost. It's not science, but it gives you an idea what it is. That's where I was coming from. Go ahead, Madam Chair.
No,
I'm finished. I could keep going, but go ahead.
Laura Sedkamp.
Sorry. So I know this waiver isn't live yet. It's the child waiver, and we're worried about the wait list on that. So even though House Bill 6 said that it was really meant to keep children in their home, The way that we have seen the write-up, and even in response to our concerns and our questions, the response was that the priority will be given to children either already in custody or in institutions. So what about the parents that want to keep their kids at home? Are they going into an indefinite wait list? Are you all prepared to deal with that? And going back to Representative Fleming's question about the costs, we never saw any math on that to see, you came up with 100 slots. We're curious to see where did that number come from? And then really just one of our big other questions is all your other waivers have participant-directed services, and those are specifically excluded in the child waiver. So this child waiver seems to be contrary to quite a bit of what you all have commented on the others. So I'm really curious on going forward with this one, what's going to happen, and how do you even justify ignoring the intent of House Bill 6 to keep these children at home?
We do feel like we met the requirement for House Bill 6. And so we did, there was $14.7 million out appropriated in state fiscal year 26 only, no admin. And we utilized that money to develop a plan for those children that are falling through the gaps. There are no priorities. There's no priority. There's no priority list.
We didn't establish any priority populations, although I recognize your understanding of that communication, but we have, even in our response to public comment, been very clear that we want to make sure that kiddos stay at home in their communities, in their schools, with their families to the extent possible. And that's where we've gone with this. We have had to consider residential as a service in this waiver, simply because we are aware of those children who are going out of state to receive services, who are sleeping in DCBS offices. There's a need there that needed to be addressed. And we have to recognize, again, we're talking about significant behavioral health or developmental needs, children who have a history of contact with multiple systems, whether it be DCBS, law enforcement, juvenile justice systems. So this is a high acuity population that we are supporting. That also lends to why PDS wasn't included, because this is intended to be, again, the highest of the high acuity of children, and we want clinical professionals handling these cases.
So in Tennessee, they reached out to the faith-based communities. Have we done that at all? Tennessee had much of the same problem. Kids in offices, spending the night in offices, and they were the hard ones to place. They went to the faith-based communities. Have we done that? It solved their issue.
I can't speak to the faith-based communities if we've reached out. If the faith-based communities chose to become some type of waiver provider, they can provide services, but they would have to meet the requirements that CMS has to be a provider. So I know a lot of folks in my community, I live in a small community, use faith-based services. So we're not opposed to it or anything like that, but they would have to meet the requirements as any other provider would have to. I would mention on the PDS services, as Carmen said, these are highly acute individuals or children. CDO or PDS is usually non-medical in nature. So if neighbor's going to be providing that service, it's a non-clinical service, right? It's non-medical.
Okay.
Representative Marzian.
Thank you, Madam Chair. I just wanted to follow up on if a slot becomes available. You said death was a different
Yes.
cup of tea. So how does that work if someone dies on it? Can we fill that slot?
So if someone were to pass, we can turn that slot over in the next month. If they have used, like Leslie said, even a 15-minute increment of services in the current month, then we have to wait for that month to end and then recycle the slot the next month. And we actively do that. Yeah. I did want to add, I was able to pull out sort of a definition from CMS. And like Leslie said, CMS requires that waiver slots be unduplicated. CMS defines an unduplicated waiver participant as a unique individual who participates in the waiver during a waiver year, regardless of when the individual entered the waiver and their length of stay on the waiver. A person who enters, exits, and re-enters the waiver during a waiver year counts as one unduplicated individual, so you have to think of each participant as the owner of their slot. If they leave the waiver for any reason, they still own that slot until the waiver year is over. The empty slot cannot be given to someone else, except in cases of death or like capacity reserve.
Can you explain the rationale? And I don't know, it's hard to speak for CMS and other federal agencies, but do you understand the rationale behind that?
For unduplication?
Right. What she just said in terms of defining with the CMS.
I don't want to speak for CMS, but I'm sure it has something to do with them being able to for their budget expectations, because they're going to match our request, right, for the year. Or for the waiver years, the 5 years of the waiver.
Okay.
Dr. Schuster?
Thank you very much, and thank you, Leslie and Carmen. My question is is a follow-up to material that you provided, but also was discussed by Steve Shannon and Amy Stade, and that is the slots and the fact that we had done so much advocacy going into the 2024 budget session to try to address the waiting list. And I pulled some numbers. We got updated numbers on those waiting lists at our Behavioral Health Technical Advisory Committee meeting, the BHTAC we call it, on September 8th. And I'm just looking at those compared to the numbers that we had in July of 2023. So we're roughly 2 years and a couple of months different. And these are astonishing. The growth in the waiting list is just heartbreaking to me. For those of you who understand where I'm coming from, if you know these parents and you know these families, and particularly the parents, as Laura talked about, kids that are born with Down syndrome are put on these waiting lists before they ever leave the hospital after birth. I mean, they are on there for years and years and years. Meg Bowden, who was the first person to speak in our public comments, talked about her daughter and how long they waited to get a slot, and then how much longer they waited to get the person-directed services, the PDS. And she had been providing all that care, of course, unpaid for, and trying to hold down several jobs. But I just want to ask you if these numbers sound kind of accurate. So the number we had in July of 2023 for the home and community-based waiver was 1,094. And the most recent one I have is 5,367. So you've gone from roughly 1,000 to more than 5,000 in that period of time. In the Michelle P. waiver, we went from 8,398, so 8,400, to 9,700. Still is an astonishing number of people to be on the waiting list, but not that rapid increase that we saw in HCB. And then in the SCL, we went from 3,200 roughly to 3,700. And just a note about the cost, SCL has a residential component. The ABI acute and ABI long-term have a residential component. That's why they're so expensive. I mean, you've got to take into consideration, to be real personal, I just went through this with my sister with an acquired brain injury who was at a nursing home in their memory care. And it is by far the most expensive service in a nursing home to have that memory care. So I guess what do you make of that huge jump in the HCB? I mean, I have my own guesses about who who the folks are that are making up that jump, but to go from 1,000 to 5,300 in a 2-year period of time is just, mind-boggling to me. Do you have any idea who those folks are?
I'll start the conversation, and Carmen can chime in. So, when the other waivers
We're having
filled-
trouble
Can you
hearing
speak into your
I'm
microphone?
so sorry. When the other waivers filled up and there were no slots available, HCB seemed to be the second choice to go to, right? Or maybe it was the first choice for some folks, but there was no wait. It had lots of slots available. Thousands of slots were available, and they just filled up very quickly. Some of which maybe have wanted Michelle P. waiver, but went to HCB. Both of those have PDS components. Is there anything else? That's probably the biggest, is once especially the Michelle P. waiver filled up, then we noticed it started trickling over to HCB.
So that network that we know goes on among parents who are trying to figure out what the heck to do with their child who was just born with a significant disability, I'm sure they keep track of those numbers, and I'm sure the word spread quickly that HCB was the place to go. I'm going to guess that a lot of those additions in the last 2 years are young kids, newly diagnosed or actually newly birthed with significant disabilities.
Dr. Schuster, we actually had these exact numbers at a previous presentation. I don't have them with me today, but we have already pulled the time frame on Michelle P. filling up, then the backfilling of HCB, taking those open slots, as well as the proportion broken down by age in each waiver. I'd love to provide that for you outside of this when we can get our hands
Yeah.
back on it.
Yeah, I would love to see it because I think it speaks to the work that a lot of us did on what we thought was going to be the child waiver. And as a clinician, I certainly understand dealing with the kids that are sleeping in offices and sent out of state and have the highest acuity. And it makes absolute sense to me that they would not have a PDS option because you really need clinician judgments there. They are the most costly kids because they have been involved in the legal system, DCBS. Many of these kids, if you look at them, have been in 8, 9, 10 foster homes. Many of them are overprescribed psychiatric medications because their behavior is so out of control. And I know that we've worked with U of L to try to tamp down that, but so they're a very needy group, but I don't want us to forget those kids whose parents really need this assistance. And I'm going to warn the legislators, we were there in 2024 on the budget, and those same groups are going to be back. I mean, you all, on top of all of the other budget requests that you're going to get, we're going to be back with an even bigger number. Steve's going to have to redo his no wait in 8 years or 8. Because the cost is going to be very, very high. But I don't think we can afford to have these families just sit. And I know they're getting other Medicaid services, many of them, but they need that intensity because we know that early intervention with these young kids is so, so critical.
Co-Chair Fleming?
Thank you, Co-Chair Adams. Last time we mentioned, actually, Senator Berg asked this question, and y'all did not, and I don't want to steal her question, but it wasn't answered, and I want to follow up on that in terms of the time on these wait lists. I know you said there's 2 processes. You got Medicaid, and you have the wait list. So can you give us an idea by each waiver in terms of a number of days that folks wait?
Yes, sir. And I okay, good. So I broke this out. We ran the calculations in 2 different ways to make sure that we met your question. The first one was application date to the point in time when, as you said it, when we say yes, meaning you've been assessed and you meet level of care for this waiver. So application date to the point in time that we say yes. I also calculated the point in time when we say yes to the point in time when services actually start. So I'm going to give you those numbers. All right. So for our ABI waivers, Application to we say yes, you've met level of care. If you take out the wait list, on average is 36 days. Home and community-based waiver on average is 27 days. Michelle P. is 52 days. And supports for community living is 39 days. So that's those what we can control. That's the assessment time, our turnaround time, how quickly are we working this? If you consider, we've said yes to the day that services start. And like I said before, we're looking for a case manager, we're writing a plan of care, we're making sure that we're financially eligible and that sort of thing. So this is sort of out of our control. Average time there, this is again in days for ABI, 38 days. HCB, 54 days. Michelle P, 88 days. And SCL, 25 days. So if you take those two together, again, this is disregarding the days that someone might sit on a wait list. The average total time from application to I've started services, if I look at all of them, is about 80 days. No. Yes, ma'am.
I may come back to that. I do want to ask a question, and that is for the waiver rate increases. Does DMS, do y'all use the entire appropriated fund amount to provide the rate increases?
Yes, sir. The $331 million over the biennium budget that was appropriated, the money has been spent. Yes.
Yes. Okay. All right. Let's see here. The other question I have, during the last presentation, you mentioned some issues with WASCARE doing the assessments and that every WASCARE denial goes back to DMS, to you all. I guess, why do you contract with DMS if y'all do the ultimate call?
That's care. He's talking about care.
Care-wise. So we're doing that specifically for the home and community-based waiver, just to ensure quality. At the end of the day, it does fall on DMS's shoulders and those decisions.
But why have CareWise? If y'all going to do it, why can't y'all do everything? Why can't you do that? And then what is the contract amount for doing that?
I don't have that with me. I'm sorry.
Okay,
Can we get that number? Can you follow up with us on that number for CareWise?
it's pretty significant, by the way.
Steve?
Yeah. A couple of questions. I want to understand the wait time data. So that doesn't include when you get on the list, right? That's when the application's approved, so they're moved on. How long is it once a person gets on the list? Because that's what I hear from families. It's one family calls it the list of no hope because it takes so long.
So I do have the average number of days right now for each waiver that someone would be on the waiting list.
Okay.
If you'd like that,
Yeah.
Steve. Okay. So for home and community-based waiver, the average number of days on the waiting list is 119. Michelle P. is 1,264. And SCL is 2,823. So, again, in the interest of answering what I think the heart of the question is, and that was getting at how efficiently are we working, we disregarded the number of days on the wait list in those prior figures.
Yeah. So Michelle P. is pushing 4 years, a little shy, and SCL a little shy of 7 years. I think that's, for me, that's the real number. It's, that people are that's what Sheila talks about and we've talked about. That's a concern. Another question, please?
Yep, and you're our last question.
Okay. When you talk about the average annual cost, can I use that number to project what like 100 slots would cost, 200 slots would cost? No.
No.
Is
I
it-
gave you averages, but the way that CMS reviews for budget neutrality is totally different, and it's a comparison. You can't. It's like apples and oranges. It's not an apple to an apple. I can give averages if you ask me for that, but that's not what the cost of the waiver would be. You can't multiply the average of the member times 100 slots. There's more that goes into consideration for that.
What else goes? I mean, the traditional Medicaid side goes in, right?
Yeah, and you have, yes, traditional Medicaid.
And some of these folks are already there.
Yes, and you also have to think about if it's applicable, if a child's getting EPSDT benefits, that would be added. I was thinking of some things from earlier, but there's several things that go into that calculation, and we have to find a comparable rate facility that they'll approve, and then we have to average those days of stay. So it's not just the 189 people that are at Oakwood, for example.
Right.
It's who at Oakwood has been there for the 9 months that compared to this waiver. Okay. And then they compare those people.
Okay. Thank you.
Thank you, and I appreciate y'all being in the hot seat today. So thank you for your testimony. But before we move on to our next set of presentations on Medicaid delivery models, I just want to take a moment that no one is reading too much into what is on today's agenda. You all are finished.
Oh, okay.
Yeah.
Thank you.
We had hoped to hear from the Kentucky Association of Health Plans and our managed care organizations as part of our discussion of Medicaid delivery models today, but due to scheduling difficulties, that presentation had been postponed to a later meeting. Co-Chair Fleming and I did not want anyone to think that just because we are discussing alternative delivery models from our MCOs, that it is any sort of indication that then the board or the General Assembly have any intention at this time to move away from managed care. But one of the primary purposes for this board is to ensure that members of the General Assembly are informed and educated on the Medicaid program, and part of that education will focus on how other states administer their Medicaid programs. And that is why we have invited Allison Adams from the Foundation for a Healthy Kentucky and Dennis Smith from Medicaid Strategies to provide an overview of the options Kentucky and other states have in how we deliver Medicaid benefits and administer the Medicaid program. So there are other options out there. And with that being said, I would like to invite Allison Adams up and to discuss the accountable care Medicaid delivery model. So please introduce yourself for the record.
Good afternoon. Allison Adams, the President and CEO of the Foundation for a Healthy Kentucky. Thank you for the opportunity to be here.
And I need you to, yes, raise your right hand, and will you please swear or affirm to tell the truth, the whole truth, and nothing but the truth?
I do.
All right, please proceed.
I promise I'm going to proceed. Thank you for the clarification before I came to the table. I think it's important to recognize that here representing the Foundation for a Healthy Kentucky is that we're giving you options to consider as we recognize what our health status are in the state of Kentucky and how we can move to potential alternative delivery of healthcare that includes community services and represents the social determinants of health space as we're improving health outcomes in Kentucky. So with that said, we're making the case for you to consider a set of transformative healthcare delivery models, accountable care organizations, as well as accountable health communities and accountable communities for health. These models are reshaping care across the United States, and they share a common theme. They provide whole person care, they pay for value instead of volume, and build healthier communities through regional collaborations. These models represent smarter, community-driven approaches that improve outcomes while lowering cost. In the interest of time, I won't remind everyone the health status of the state of Kentucky, but we know that we're living sicker, we're dying younger, and taxpayers shoulder billions in the cost. Our current health system is fragmented. Hospitals, clinics, schools, and social services often work in isolation of each other, and we end up treating the symptoms instead of meaningfully addressing the root causes of the health. Our current model also fails in many cases to adequately address those social drivers of health. We know those are the conditions where people live, work, play, and learn. And we also know that when we address these outcomes, when we address these conditions, we know that they have a stronger influence on the health outcomes over clinical care. This committee was chartered because delivering healthcare system this way isn't giving us good returns, and Kentucky is paying more. We get little improvement in our health outcomes, and the gaps between our zip codes continue to grow. To change this trajectory, we challenge Kentucky to have proven models that unite providers, coordinate care, and connect communities while holding the entire system accountable for both outcomes and cost. Unlike managed care organizations, which focus largely on administering benefits at the lowest cost to the organization, these models embed accountability directly into how care is delivered, how communities invest in and improve health. You need the slide to keep it all together because all these ACH, and ACOs are kind of a little bit confusing. So just bear with me as I deliver these three different models of care. So starting with an accountable health community, or AHCs, this was a federal demonstration model launched by the Centers for Medicare and Medicaid Services to bridge the gap between medical care and social services. AHCs use what are called bridge organizations, and these organizations screen Medicare and Medicaid patients for needs like housing, food, and transportation. And we know that these are the things that drive 80% of our health outcomes, and they make referrals based on those identified needs. They then connect the patient to the community resources and track whether those connections have made or will make a difference. In states where this has been tested, we've seen lower emergency department use, better chronic disease management, and more efficient use of health resources. In other words, we're seeing healthier people, lower cost. For Kentucky, an AHC would mean we stop treating social needs as someone else's problem and start addressing them as part of healthcare, using traditional healthcare resources to manage people's care by also supporting the cost of the referrals to those community-based organizations. Accountable for community health is the ACHs, is the approach that is much broader, and it moves beyond the traditional healthcare to focus on the full range of factors that shape the person's health. And so ACHs serve as conveners, and they bring together diverse stakeholders like hospitals, public health departments, schools, employers, policymakers, community-based organizations, and residents and or patients to design and implement a community-wide strategy that improves health outcomes. ACHs use funds like wellness funds that pull together resources like Medicaid, hospital, and philanthropic dollars to invest in prevention and the local health priorities. This creates a system where every partner has skin in the game with shared measures of successes. Progress is tracked through leading indicators like early prenatal care and tobacco quit attempts, and lagging outcomes like infant mortality rates and cardiovascular disease. In Kentucky, by geography, our area development districts would make a natural regional unit for an accountable communities for health. If the state could implement a health data dashboard with unified data platform, predictive analytics, and community dashboards, we could track progress, access, cost, quality, and the equity across our zip codes. ACHs could use that information to guide local investments. For example, if the data shows preventable ER use is rising in a region, the HCH could respond using those wellness funds towards after-hour urgent care or community health workers. So they can design, where to direct those funds based on what their data is showing at the community level. In this way, a health data platform would identify those needs, and they can deliver on-the-ground solutions, creating a continuous loop of see, act, and improve. ACH models are the cross-sector collaboration that can help move the needle on population health and equitable access to care. And finally, accountable care organizations, or ACOs, bring doctors, hospitals, and providers together to coordinate care for a defined group of patients. They're rewarded for keeping patients healthier and avoiding unnecessary costs such as repeat tests, conflicting advice, or gaps in treatment. Their payment model often includes share savings. If care costs less than expected and the quality targets are met, the ACO would keep a portion of those savings. More and more, we are seeing something called, you all have heard this, capitation, which is a predictable per-member payment to cover all necessary care. By shifting this financial risk from payers to providers, these models encourage prevention, whole person care. And for patients, what that translates into is better coordination, fewer errors, and the right care at the right time. And so think about this as a ladder of accountability. ACOs are accountable for the patient's health care. AHCs are accountable for connecting patients to social services that determine health, and ACHs are accountable for the health and well-being of the entire community. Each step builds on the other, and together they form a continuum of smarter, more sustainable care, leading to better health outcomes for Kentuckians. Taking one step is good, taking all three is great, but meshing the best of the models together and creating an innovative and transformative model of care would be life-changing for Kentuckians. So to you all, as members of this committee, Kentucky has a choice. We can continue with fragmented high-cost care or move towards a system that's coordinated, accountable, and community-driven. ACOs, AHCs, and ACHs, they're not theory. They are proven models delivering results across the U.S. They show us that when accountability is built into the care, we can build smarter, we can spend smarter, improve outcomes, and strengthen communities. And that's the challenge I believe is before us today. So as you continue your work, we urge you to consider how transformative approaches can be adapted in Kentucky so that every community, urban and rural alike, has the tools to deliver better health at a better value. Is it possible to convene a group of experts? It is possible to convene a group of experts to explore what a Kentucky version of an accountable communities for health should look like, and then move forward to implement that model. This moment is a chance for the Commonwealth to lead, proving that we can lower cost, improve outcomes, and give every Kentucky the opportunity for a healthier future they deserve. And with that, I'm happy to answer any questions. Rep. Fleming, Senator Rocky Adams, I think that just to recognize that we're here to challenge a different way of thinking. I'm not the subject matter expert on all the details of each of these potential models.
Thank you very much for your presentation. We do have a question. Senator Meredith.
Thank you, Madam Chair, and Ms. Adams, thank you for the graphic here. It was a very nice piece. Trying to get through this alphabet soup. Now, those three models that you have detailed for us, which one would be your preferred model for Kentucky, and how is it superior to what managed care is presently doing?
Well, if I had to choose with just this three, it would be the accountable communities for health, which is that whole approach that embeds the community accountability into it, which I think is the most important piece as we're addressing social determinants of health. But I would also say that, like I said in the presentation, is figuring out a way to mesh all of these three together to create a transformative system of delivery of care for Kentucky. So to answer your question, Senator Meredith, I'd love to have the opportunity to convene a group to really have a look at what all of these models could do and get the best of each of them and create a delivery system in Kentucky. How they're different, MCO models are built on quantity over quality at the lowest cost possible. We have little accountability in the patient's outcome, and it's not patient nor community centered. And so there's a lot of mistrust in the coordination between the payer, the provider, and the patient, which doesn't lead to good outcomes for anyone. And so I think the other difference in these accountable care organizations is simply that any savings, you all have heard some other presentations along the way where we've had organizations, healthcare organizations, step up and do the right thing and begin to start coordinating care for their patients because it's the right thing for the patient. But when that care coordination happens and the outcome is improved and the community supports it, for that said patient, the organization that is coordinating that care doesn't realize that savings. It stays within the managed care organization. So when you're doing the body of work, especially out in the rural communities where we have higher need patients and the community, the providers are seeing those needs, they're stepping up and doing the work, but they're not being compensated for that said work. So I think that that's the difference we see here in having an accountable community model. And also, I think that when they're implemented together, it would be a bold step towards a healthcare future that does treat the whole person, where they're living, where they're working, and where they're playing. And again, we're not just treating symptoms; we're repairing the system.
Thank you. Good answer. Thank you, Madam Chair.
Senator Douglas?
Thank you, Madam Chair. Allison, I agree with the alphabet soup, but it's okay. I know the ACOs talk about shifting accountability from the payers to the providers, correct? Okay. I'm looking at these models and I'm trying to figure out which one of these actually creates patient expectations, tracks patient participation, and then adjusts benefits based on patient compliance.
That's a good question. So when I talk about the meshing of, I think that when we build in the accountable community for health, we begin to build systems that hold the patient accountable. I also think that if, there are model organizations who have figured out how we are holding patients accountable because the provider is counting on them to be accountable. So then we have community health.
Well, if I may, the provider counting on them to be accountable has nothing to do with patients being accountable. Having sat in that seat for almost 40 years, I assure you of that.
Yes, I appreciate your perspective. And when we think about when they leave your office, what community they are going into, whether it's supporting your recommendations, your work, whether we have the supports that your patients need to make the right decision, and if they don't exist, then that there is an issue, right? But if we focus on building a better system of care in those social determinants, then your patients have a better opportunity to make the right choice, to follow your directive. They might not always, but they have the opportunity.
You and I have had this. Most people here don't know. You and I have had this conversation a number of times. So, and I'm not much with dancing around. I'm trying to find out which system sets up an accountability, not opportunity. I push back a lot against that word opportunity, right? Because we can have all the opportunity in the world, but if we don't get out of bed, it doesn't matter. It doesn't matter. So I'm trying to figure out which one of these would ask for more accountability from those people who are receiving care within the healthcare system. Something we almost never talk about.
Neither.
Okay, thank you.
But can I clarify?
That's up to the chairwoman.
The answer is neither, and the clarity that I would like to shed on this is that if we were looking at the ACH model, that builds in that whole community. So when you think about incentives or disincentives or those dashboards that are creating transparency of where the community sits in their health outcome, we suddenly, it's not just an individual problem. It's a community problem in respect to where we sit in outcomes. So in a world where we have individual accountability that is necessitated, we also have the opportunity to hold each other accountable in an ACH model.
Just to let you know, I always hated to have to run extra suicides because my fellow basketball players couldn't hit a free throw.
Co-Chair Fleming, our last question.
Thank you. Ms. Ann, thank you very much, and I enjoy our conversations in the past. You come from a very good background and very good perspective on things. I guess a question and then a statement. How is the ACO any different from the PLEs, which is the provider-led equity, or I think I got the right E? Provider-led, basically. How's those two different? Because you made the point in terms of, in terms of this is literally physician, provider-led, and so forth. What's the difference between those two?
I can't answer that question. I'm not familiar with did you say PLE? Is that what you said?
Yeah, PLEs.
Yeah, I'm not familiar with that term. What I want to just clarify is the accountable care organization is a group of providers who are working together to serve the patient, and then they are compensated according to the patient's care and outcome. And so I'm not sure how it's different. I'm not an expert on that.
And that's fine. That's fine. As Co-Chair Adams mentioned, we need to look at all different types of options out there in terms of trying to go wherever we need to go. But this is going to be important. Either if we stay where we are, okay, we need to modify or change that or address that. But collectively, we need to come up with where we want to be, and the model should be supporting what our goals and objectives are from a collaborative, collective point of view from various segments of the Commonwealth. So that's part of what I think the board is going to need to be considering in terms of where we're going to go and what type of model is going to support that. Once again, our current model could be fine, but we need to look at changing this, that, and the other, or say, no, we need to do something totally different. But this board needs to look at all options in terms of going forward. Thank you.
Okay, now we have our last question. Vicki Yates-Glissom. Microphone.
Thank you for your presentation. I appreciate it. My question is dealing with the issue of leveraging of data, because with the accountable health models, data is kind of everything. And we have our challenges here in Kentucky. It seems that we collect a lot of data, but being able to properly access that data, I think, is paramount for these models and for other models. And I would appreciate just your thoughts about things we need to do differently so that we can actually either collect the right data and then secondly, access that data to be able to make these models work.
I couldn't agree with you more.
Yeah.
I've been in many of your all's offices talking about data access and data transparency. Where's the money being spent? Where are there opportunities to improve? Vicki, your question is, what can we do better? And I think that Kentucky establishing a dashboard of our health status, like where our money is being spent, what outcomes are we getting, and what does that look like at a community level, which it can be done. There's 23 other states that have a data utility, a data dashboard, an all payers claims database. There's opportunity models to look for. I think that the most important piece is recognizing that if you're in the system, you're part of the system, and that data sharing should just be the norm, because one entity can't improve the health of Kentuckian by themselves. And if we're all not sharing our data, we don't know what levers to pull in order to improve the health outcomes.
Are there 2 or 3 states that you think are doing this really well, so that there is like a data dashboard, and that those states are actually having registries, collecting data, and then pulling that data out so that it can be used effectively.
Yes, our neighbors to the north, Indiana, is doing a really good job with this. But like I said, 23 other states. I'm happy to tell you more about the data opportunities that exist to look at. And I think it's also important to recognize that it's not just data access, it's an analytical piece. Just because you have the data, we have to know what the data means. And
Exactly.
then, utilize your statewide partners to recommend, again, what levers to pull based on what the data says.
And if they're doing those analytics, that is shared with our citizens.
Correct.
Yes. Okay. Thank you.
All right. Thank you, Allison. I really appreciate you testifying today. Next up on our agenda is we have Dennis Smith. He's going to join us by Zoom, I believe. He's going to educate this committee about a few other Medicaid delivery models. Do we have Dennis on the line?
Can you hear me?
Okay, Dennis, you are live with the committee. Would you please identify yourself for the record?
Certainly. Sure. I'm Dennis Smith. I've been in and around Medicaid for about 40 years. I served as Medicaid director in Virginia. I was a health secretary in Wisconsin, also have served in California and in Arkansas. Been on Capitol Hill, helped to create the Children's Health Program in the Balanced Budget Act of 1997. And then 8 years almost 8 years as Medicaid director at CMS under President Bush 43. So I've been around a while.
Dennis, you sure have. At this time, Dennis, do you mind to raise your right hand and swear or affirm to tell the truth, the whole truth, and nothing but the truth?
I do.
Okay, thank you very much. Please proceed with your testimony.
Thank you very much. I really appreciate the opportunity to talk with you this afternoon. And I enjoyed all of the previous presentations, and would start out with, we have to do something different. When we look at us baby boomers getting older, the demographics are against us in terms of supporting an older population, long-term services and supports. The greatest source of long-term services and support is unpaid, generally family caregivers. But Medicaid is the largest single source of paid long-term services and supports. Medicare pays only very little. Most of private insurance does not pay. Medicaid is out there. Second part is we have an imbalance between supply and demand. The Affordable Care Act came along in past 2010. One of the things that we were told that the cost of healthcare would go down on average by $2,000 per family. We know that that did not happen. We increased demand, but we have not increased supply. We know that everywhere in the United States, except in New England and parts of mid-Atlantic, we do not have enough physicians per 100,000 people. We don't have enough nurses. The one good thing, one particularly good thing that healthcare does is to create new jobs. You create techs, you spin off into more and more roles. And I think telemedicine will help give us those things. So we're going to have more physician expenditures. We're going to have to rely more on technology for the information, for that bedside information. I'm going to go through I sent a deck. I won't go through it page by page. There's lots of words on there, but I want to get mainly to your questions, so I'll zip past it through it pretty quickly. So on the second slide, medical versus healthcare, and generally we talk about healthcare, but for the most part, what we really mean is medical care. And so these are some quotes from Kenneth Arrow, who was a Nobel Prize economist, again, making the distinction between the medical care industry does not necessarily mean health. The reason I bring that up is because this statement was made in 1963, before Medicare and Medicaid had even been created. This year's the 60th anniversary of Medicare and Medicaid. And now we're starting to come full circle to what I think Dr. Arrow talked about in terms of the real issue is health. We want to be healthy so we can do things, et cetera. But we have all of these other things that are involved in our health as well, that are beyond. The second slide is what I call the Rubik's Cube of the American health insurance system, again, distinguishing between healthcare and health insurance. And you know that little plastic game toy that you can move around the dial. So basically, we have six, you can be in one of six sites: employer-sponsored insurance, large groups tend to be self-insured. They're not purchasing coverage for their employees because they're self-insured. The smaller group, they are purchasing coverage. They're getting bids, et cetera. Medicaid is not technically health insurance. It is medical assistance, but it is now the second largest source of coverage in the United States, the largest being the employer-sponsored 150 million people. Medicare, the individual market, we have the unsubsidized and the subsidized market, and then we have uninsured on that model also. Because again, if you twist one side, you can reduce the number of uninsured or you can increase the number of uninsured depending on how to do it. We have the next slide, patients, providers, plans, payers, processors, producers. The slide 5 threw in a couple of highlighted quotes from Kristen Madison, who has written extensively in it. And again, because we often talk about the healthcare market, but we have generally healthy markets very much depend on informed consumers to become informed purchasers. We don't really have that in healthcare. And we even have less of it in Medicaid. Managed care, for example, most people are not choosing their own health plan. Depending on where you're at, 75 to 80% of people in managed care gets assigned into one of those health plans. The individual did not make the choice itself. But it's the imperfect knowledge and the lack of information that we're constantly struggling against. Slide 6, the delivery system. We talk about a system. In my estimation, at the very least, it's not a complete system. It's not a complete system that you think about of being in constant communication. We have a fragmented system, whether providers are in different silos, not talking to each other, et cetera. So our flaw in the delivery system is trying to again, I think we need to move beyond the current system to provide another level. First, you have to fill out the continuum of care. So you think about people with mental illness, for example, who go from crisis, prevention, et cetera, hospitalization, then back out again. In the fee-for-service world, we can in traditional Medicaid fee-for-service, we affectionately call that fend for self. So depending whether what your recreation is in your state, you get a fishing license or a hunting license, and you're on your own in the fee-for-service world. Most of these individuals are people with, especially people with mental illness, people with intellectual disabilities, they need the extra help of someone helping them to navigate and coordinate the system. Excess medical spending. Again, we're all aware that the United States spends higher per capita, and we often talk about it's the cost of healthcare. In my estimation, the gold standard, the baby at the first day of life or Grandma Smith on her last day of life, if she is getting the appropriate care, that's what we're looking for. The real issue that we need to address is the excess cost of health care. And the excess cost is generally driven by overutilization and underutilization. Prevention, if you underutilize prevention, you're going to end up with greater healthcare costs somewhere else in the system. But overuse is the number one rank on there, over $1,300 per median per capita estimate of overusing care that, again, as the quote says, without doing you any good. So again, we can reduce that number without affecting the quality of care. Let me skip ahead to slide 10, what I call the 5 pillars of Medicaid. But in reality, any health insurance can fit into these 5 pillars at all. You're dealing with eligibility, benefits, service delivery, financing, administration. I particularly was interested and appreciated being invited because I believe service delivery is the key to not only reforming Medicare, but throughout the system and the way care is delivered. Fee for service generally, as you all know and have heard many times, rewards volume over value. That's what the fee for service system does. Slide 12, administrative cost conundrum. Again, whether you are Blue Cross Blue Shield or Kentucky Health or fee for service Medicaid, every insurance company has to perform these same functions. Excuse me. So the irony of all this and the difficulty of it is, in order to reduce waste, fraud, and abuse, you have to actually make greater investment to do that. One of the things that always gave me heartburn at CMS, Medicare talking about their low administrative costs. Well, which is very true, but their improper payment rate, again, a lot of money out the door because we don't have enough resources dedicated to reducing waste, fraud, and abuse. You have to invest more to be able to measure quality improvement. I think this is an area in particular. I think every state wants more in terms of outcomes. Why are we investing in all of these? And again, 90% of the Medicaid population nationwide is in some form of managed care. So again, states are saying, why aren't we getting better results? Why don't we see improved health outcomes? And invest more for collaboration and coordination. And you'll see later in my remarks, that's really, I think, where the key is. Why do states use managed care? The fee for service system, that is embedded in the Medicaid statute. So again, when they wrote it back in 1965, there was no such thing as managed care, right? So people had a right to choose their provider. So, but as we have discussed, fee for service incentivizes volume. So the 3 major types of managed care, 3 major models: comprehensive risk-based managed care. You have that in Kentucky. I believe you have 5 different health plans. You have organized your state by region. I think you have 8 or 9 regions in Kentucky, and so they form markets in there. You have some national players there in Kentucky. Those are full risk. Generally, we talk full risk, but we don't always mean full risk. Long-term services and supports, for example, in most cases are not included in managed care. They're outside of managed care. Primary care case management, where you are paying a monthly fee, typically to a doctor, to do that primary care case management. We tend to pay, those are pretty modest fees in general, and they're helping them, again, it's an incentive to make certain the child gets the proper immunizations, things like that. And then limited benefit plans. These are prepaid plans. Dental managed care, for example, is a limited benefit package plan. Non-emergency medical transportation, that is a limited benefit plan. Overall, managed care is now accounting for about 50% of Medicaid expenditures, but they vary by population and by services. The next slide added a couple more: patient-centered medical homes, health homes, accountable care organizations. Those are managed care models also. The PACE program, all-inclusive care for the elderly, is a managed care model. So on slide 15, why are states still using managed care? Budgetary reasons is one of the major reasons now. And typically when you go into managed care for the first time, you would see some savings in the first couple of years. But after that, it is for stability and predictability in your budgeting. Generally, you have multi-year, they have multi-year contracts with their providers. So it tends to be a little bit more predictable, even though they don't, even though in managed care, and we may think that they have come up with new ways of paying providers, and there is some of that, but by and large, they are still just using the Medicaid fee-for-service fee schedule. So they're paying the doctor the same of what fee-for-service is paying the doctor in many respects. They are serving the administrative function, and you've given that over to them. A large part of it, though, is, and you're contracting out those administrative functions. You tend to think that the private sector maybe has figured it out to be a bit more efficient than your state system of running your Medicaid management information system, which is what pays claims, et cetera. But a big reason for many states is that it can generate a premium tax. So the premium tax is a source of revenue to the state. So you get to use that instead of general funds. There are different authorities on page 17. I won't go through each and every one of them, but there are a variety of options that states can seek their authority, and there's different reasons for using different authorities. Slide 18 goes more to the limited benefit plans that I had mentioned. Behavioral health historically was carved out of managed care. And now we know more and more it's people with serious mental illness, it's kids with emotional disorders, people with substance abuse. They are among our highest cost drivers in the Medicaid program. And again, when we talk about averages, that's useful to some extent for understanding the budget. But we are still in a situation to where it's a small percentage of people who drive the greatest amount of the cost. You know, it used to be the old 20-80 rule. In some respects, it's now closer to the 10-90 rule, in which 10% of the population is accounting for 90% of the cost. So managing children in managed care, you're not changing things much, really, right? They don't go to the hospital as often as adults. They're not using services the same way adults there. The managed care, but that's managed care was built actually on the least expensive populations. Slide 19 is just breaking down by percentages. You can see it's the children and healthy adults who are the biggest large percentages enrolled in different types of managed care. More and more, we're seeing states move to really focus on these specialty populations. Again, people with serious mental illness, substance abuse, etc., people with intellectual disabilities. And more, we are finding out, and again, providers tend to stay in their traditional roles. We have found this in Arkansas, and I helped to develop what we call the PASS program, which is exclusively high-cost individuals. Behavioral health providers and providers to serve people with developmental disabilities. They didn't want to cross their populations. The behavioral health people said, no, we only do mental health. The DD folks said, no, we only do people with developmental disabilities. Until we started showing them the data, so many of your populations have both. When you start looking at the reentry population, if you have already, for example, you will find a very high incidence of mental illness, people who are in your jails, people who are in prison when they're coming out of prison, extremely high acute care costs as well. They have much higher incidence of chronic health care conditions, etc. So again, now we're starting to see managed care to start looking at these specialty populations. Certified community behavioral health clinics, perhaps that has come up, and those of you who are participating on the rural health transformation that has come out of Washington as part of HR 1. You know that there's $50 billion in there to the states on rural health transformation. Mental health, there's been a new model that is being well advertised called Certified Community Behavioral Health Clinics. But in reality, that's a 40-year-old model. We're just giving it a new name. Again, a comprehensive risk base, including long-term services and supports. And we did that in Arkansas because realizing these populations have very high, what we call halo spending, the regular acute care, et cetera. They have a mental health serious mental health condition, but they are also high spenders because so many of them have other types of chronic health conditions as well. So the next slide is where I think we really need to start focusing on. Life is a series of transitions. When you think about our different stages of life as we move through life, we need to be thinking that same way in terms of helping people transition. You know, when an individual has been hospitalized, and one of these things that we talked about with our mental health providers. Well, now your patient is in the emergency room and has been hospitalized. Did you know that? It's like, no, what we know is when the patient comes into our clinic, they have no information outside that clinic setting. Well, they need to know, right? And how then to make that transition successful when you're leaving that home. So in a post-acute care situation, you are either going to some type of skilled nursing facility for a rehabilitation stay. You're going to go back to your own home with or without home health. How do we make that transition successful? And again, the family dynamics have changed dramatically on us. You know, our children don't live nearby anymore to help us with those transitions, etc. So it's the transition that is going to help determine whether or not we get re-hospitalized, and whether or not we stay in a skilled nursing home instead of being able to go back home. It's about managing those transitions. So again, a couple of different models that we have. Home visitation for women with high-risk pregnancy has proven to be very effective and helpful. In Arkansas, we have now extended that for 2 years after the child is born. So again, and home visitation, you're helping not only with the new mom to understand how to take care of that baby, but you're also imparting life skills as well, and helping to, through that critical postpartum period, et cetera. But again, these specialty populations cannot navigate this system on their own. So where will care be delivered in the future? Again, I think that there are more and more, I should say fewer and fewer, things that have to be delivered in a hospital. 40 years ago, if you needed oxygen, where were you? You were in a hospital. Now you can take your portable oxygen tank and go play a round of golf. Again, this is where I think technology is going to help be a major part of the solution. So is Medicaid keeping up with that to make certain we have access for people to those new technologies? But again, it's to me about breaking down the silos. It's completing a true system of care, which requires constant communication among all of the parties. And again, just from the demographics of us baby boomers, we have got to do much, much more to support our caregivers. We have all kinds of tax credits to weatherize your home, et cetera. Why shouldn't we be thinking about tax credits to make your home safer for an elderly person to live in? Why shouldn't we do more about thinking about helping those caregivers? The average caregiver is providing about 3.5 years of care. Again, totally uncompensated. You've got families who are giving up their jobs or working less, et cetera, for that caregiver role. So this is not, as I said from the very beginning, it's not just a medical issue. It is a health issue. It's also the health of our communities as well. Sorry. I was hoping somebody was going to start interrupting me. I hate to hear myself talk.
Well, we're ready for questions if you are.
Okay. And I'm sorry I talked too long.
No, I really thank you for your presentation. This was good stuff. And I will start off with with Co-Chair Fleming.
Thank you, Madam Co-Chair. Mr. Smith, I really appreciate your presentation. That's I'm sitting here sort of drooling a little bit on basically what you've laid things out. It's very simple, but it's to the point. I do appreciate one of your experience, but also your perspective on this. I wanted to, I guess, address two things basically, or maybe three things. From in terms of running a mental health center, I've always looked at things from a holistic point of view, your mind, body, and spirit. And it seems like, given the fragmentation that I think this Kentucky is seeing, and maybe in other parts of the country, there's not a holistic approach in terms of treating an individual, regardless of the acuity or whatever type of challenge they have. So part of my thought process is like we need to look at things from a holistic point of view in terms of providing and delivering service and making sure that folks have access and so forth. So I just want to make a statement on that, and I appreciate your comment, because we're in here in terms of looking at a long-term strategy. So whatever this board comes up with, not only at the end of this year, but also next year, we need to think about long-term strategy, because you know as well as I do, with House Resolution 1 coming down the pipe in 27, 28, a lot of things are going to be hitting the fan. And so we need to really start looking forward in terms of trying to set ourselves in a particular situation, or whatever situation comes up. My question is, Mr. Smith, is you covered a lot of topics, but one thing, one model or one approach that you didn't mention, and I want to see what other states are doing this and how basically we will go about doing this. And I'm not suggesting this, but self-funded. When it comes to self-funded type of an approach, what states are out there doing this, if they all are, and then what's your experience and perception on that?
Well, fee for service is basically self-funded, right?
Right.
So,
And I guess I'm looking at more of a global, holistic approach
Right.
to that. Yes, you're correct.
So again, I think, and I should also, I want to hasten to add, and I mentioned the different states that I've worked in. Every state is different. You have your own culture, you have your own history, et cetera. I would never ever tell any state you should do this. No, that's not why you invited me. I'm just trying to share of what's going on out there. So Kentucky has to do it in their own way. But I think that, and you mentioned the mental health clinics. Mental health, we do need to give them more tools. Most mental health providers are on the least expensive, less effective medical records system. If they are on a state's health information exchange, they're faxing things in. They don't have the same sophisticated systems that hospitals and doctors' office have. And then when you get to DD provider, they have no access whatsoever. So even in a self-funded fee-for-service system, I would still say there's going to be a lot of benefit if you can just get providers on the HIE so they can communicate with each other. I think that we need, again, in the fee-for-service world, there is still going to be needs to be a component of someone coordinating with that individual. And again, I talk about who do I give this dollar to change Dennis's behavior? I'm a frequent flyer into the emergency room. Who do I pay to change Dennis's behavior, including a family member, which again might be an option. So again, if you go that route, and by all means, I mean that's where you started in the first place. But there's still these enhancements that you can do to be able to, as I said, these people cannot navigate the system on their own.
Yeah. Well, thank you very much. And another thought I had, and I'll let other folks ask a question. I've always been client, patient, customer driven, and that needs to drive how we need to operate and how we need to deliver services. And then everything else will fall into order based on that. So it's basically, we need to serve the client, the customer, or the patient the best way we can to give them the tools in order to provide that. So thank you, Madam Chair.
Thank you. And if I could add just one thing, I mean,
Sure.
One of the things that we have found most recently with our state mental health hospital, we are now pushing ourselves, because it's a state facility, to start ordering more neurological tests, not just psychological tests, but the incidence of undiagnosed fetal alcohol syndrome, the number of undiagnosed mini strokes that individual had. So there, again, it's a very complex, very expensive population. And we need to actually, we can't treat someone successfully if we don't have the proper diagnosis.
Senator Meredith?
Thank you, Madam Chair, and thank you for your presentation. I appreciate your 40 years in this business. I've been in it for 50 years, so I've got you just a little bit. I think we could
There
have
you
probably
go.
an hour-long conversation about each of these topics, but I appreciate your insight to this. But, you know, I truly believe we have a crisis of biblical proportion when it comes to health care. We're spending $14,800 per capita in the United States on health care. The next closest nation is Germany at $8,500. China, our biggest trade competitor, is right at $1,000. We can't be competitive in the international market with those kind of disparities in healthcare costs. Plus, at the same time, we are crushing the middle class in this country from the high cost of healthcare. You mentioned some of the causes of that. It's always been my position, and I hope you can support it, that there's enough money currently in the system to take care of every man, woman, and child in this country if we just spend it the right way. And the right way is reducing the administrative burden, which you just touched on that a little bit, but I think it's one of the greatest causes of high cost. Secondly is the overutilization, which you have mentioned, in working on improving the health of the population, which traditionally hasn't been the strategy that we've embraced, but also addressing the social determinants of care. And if we could do all those things, would you agree there's enough money there to take care of everyone?
I do agree with that, absolutely.
Well, to that end, I go to your slide number 5 regarding regulating healthcare quality and information age. I point this one out because I think it truly illustrates the dichotomy in the system already, that this slide, no disrespect intended to the author of it, but this slide has no applicability to rural healthcare whatsoever, because we can't talk about marketing of healthcare when you don't have marketing of healthcare resources to begin with. You made mention about the ER visits and John Doe coming to ER time and time again. Well, the principal reason that happens in a rural community is there's not enough primary care physicians. Agreed. So we're using the ER as the primary care physician. And until we'll address those deficiencies, I'm not sure we're going to make a lot of headway in this. But I think the crisis that we're facing now is greater in rural America than it is urban America. And that's where we have the biggest opportunity to make some gains in this, so to speak. Could you speak to that?
Absolutely, and I would agree with that. Traditionally, living in a rural area, you were healthier than your urban cousins until about the early 1970s, and that has now reversed itself. So absolutely, just living in a rural area is an indicator for poor health outcomes because of the lack of access. So yes, so the question is, how do we get more access? We are, with all due respect, we're not going to produce more doctors. We're the number of doctors that we actually need in rural America. We are not going to produce the number of nurses that we need. So we've got to come up with an alternative way to change those dynamics. And I would say one other thing. I think that, and certainly I don't want to overgeneralize, but those rural hospitals were started with people who dug into their own pockets to start them in the first place. They were their community hospital. And that community, and I'll be personal for a moment. I grew up in a town of 1,500 people. When I left, we had a doctor, a pharmacist, and a dentist right there in town, a town of 1,500 people. Today, none of those three are practicing in my hometown. So what are we going to do about it? I think is what is really the discussion point. I think we can all agree that it is the access problem. And what we have now is not, even those we have are in such shaky financial condition that they are, they are at risk of going under. So by all means, but to me, that is, We shouldn't look at it as a critical access hospital. We need to go back to looking at to a community hospital, talking to the employers and saying, well, stay local. Let us do the annual school physical exams for the kids. We've got to have people, we have to have employers who will use that hospital as a resource. And the hospital itself, I think, has to change what it is going to do. And again, kind of open its doors wider. Then, we have so many other parts of our economy. We are now going to the individual, right? All of the things now you can have delivered to your doorstep. But in healthcare, we are still saying, well, you have to come to us. I think that's got to be part of the solution.
Well, we have obviously 1,000 different issues we need to address, but I think that kind of clouds the issue in itself. I think as a starting point, you've got to have a strong primary care network, and that doesn't exist, particularly in rural Kentucky. 40% of our population lives there, and only 17% of our primary care physicians are there. If we can't address that issues, I'm not sure there's much hope for rural health care in Kentucky. And then that's just not a health issue, that becomes an economic issue. It's projected that 35 rural hospitals, which would be half the rural hospitals in the state of Kentucky, could close as a result of the proposed Medicaid cuts. I think that's a little bit of exaggeration, but if that happens, it will not only destroy the healthcare delivery system for those communities, but Kentucky as well, but bring economic hardship on every section of this state. And the challenge, I think, is that it's not a big enough crisis yet. As I mentioned, 40% of our population lives in rural Kentucky, only 17% of our primary care physicians there. And why is that the case? Quite candidly, because 40% is a minority, and nobody really gives a damn. That's an editorial comment, not a question.
Okay, so thank you, Mr. Smith, for your testimony. We really appreciate your time, and we really appreciate the information. At this time, we don't have anyone that signed up for the 10-minute public comment period. Before we adjourn, I do want to point out that we are still waiting on the December 3rd, 2024 appropriation and revenue data request to DMS. We are still waiting on the May 5th, 2025 Representative Fleming data request to DMS regarding the MCO penalties and reports. And we are still waiting on the May 6th, 2025 Representative Fleming data request to DMS. Is that okay? So if we could get those hustled up, that would be, we would really appreciate that. So thank you very much.
Madam Chair, if I could I add one to that?
Yes, sir.
Back in 2023, we passed Senate Joint Resolution 54, direct the Department of Medicaid Services to look at different payment models, principally using the Area Deprivation Index. And they were supposed to have a report to us by November of 2023, as well as a study on some additional services, outpatient services. And that report was supposed to be by July 15, 2023, and it's been crickets. Heard nothing.
Okay, and what is the statute that we passed?
It was Senate Joint Resolution 54.
Senate Resolution 54 in
2023 session. Yes.
Okay, thank you. We will add that to the list. Do we have anything else from committee members before we have a motion to adjourn? Okay, motion to adjourn. Seeing... Yes. All right. All those in favor? Next meeting. Oh. Next meeting, October 7, 2025. Please make a note. See you all then.